Welcome to the Rad Onc Smart Review Head and Neck Cancer Series.
This is Session 18b, the Post-Operative Oropharynx Planning Workshop.
If you caught our last review, 18a, we spent a lot of time on the decision-making. Who gets observation, who gets radiation alone, and when do we have to use chemoradiation after tours for HPV-positive oropharyngeal cancer?
Right, and that decision, that triage, is really only half the battle.
Exactly. So today we're moving purely into the execution phase. This is where it all comes together.
The art and the science of planning. We're going to get into the details of exactly how to contour that surgical bed, which can be so subtle.
And how to select the right neck volumes, how to choose a defensible dose. Is it 50 gray? Is it 60 gray?
And, maybe most importantly for these patients, how to truly prioritize protecting their ability to swallow. That's critical for these long-term survivors.
Yeah, and this entire framework is really built on the risk-adapted approach from that big trial, the ECOG ACRIN trial.
Which we'll just call E18b from here on out. It makes it a lot easier.
Okay, and before we jump in, a really crucial point for anyone preparing for oral boards, a safety note.
Yes, this is so important. You must always state the conventional standard first.
So if you see extranodal extension, ENE, you start by saying the historical standard is chemoradiation.
Right. Based on the old trials like RTOG 9501, only after you've said that do you bring in the de-escalation data from E18b for these specific post-tours, HPV-positive patients.
It shows, both the conservative standard and the modern, more nuanced practice. It's survival technique for the boards.
Absolutely essential advice. You never want an examiner thinking you skipped the fundamentals.
Okay, so let's make this tangible. We're going to anchor this whole discussion around a mini clinical case. It really hits that intermediate risk sweet spot perfectly.
Great. Lay it out for us.
Right. Our patient is a 58-year-old man. He's a lifetime never smoker. He's had a TORS resection of a left tonsillar squamous cell carcinoma.
Okay.
And he also had a left selective neck dissection, levels 2 through 4.
So the pathology report is going to be everything here. What are the key details?
This is the entire risk profile right here. The tumor is P16 positive by immunohistochemistry.
So, strong suggestion of HPV etiology. Good.
Pathologically, it's a T2, measuring 2.1 centimeters. In the neck, 3 of 22 lymph nodes were positive. The largest one was 2 centimeters.
3 nodes, okay.
And here it is. This is the detail that changes everything. Extranodal extension, ENE, is present.
Ah.
But, crucially, the pathologist measured it. It's 0.8 millimeters beyond the capsule.
0.8 millimeters. That specific sub-millimeter measurement is the entire pivot point for our decision-making. That's what separates this case from the old conventional pathway.
Exactly. Other details. Margins were negative. Closest was 4 millimeters. He did have perineural invasion, PNI, and lymphovascular invasion, LVI, present.
Okay, so some other adverse features there.
Right. And just to confirm, the primary was totally confined to the tonsillar fossa. No posterior pharyngeal wall involvement and no nodes on the other side.
Okay, so the big question is, what's the adjuvant therapy recommendation, and how do we translate that into a really precise, function-sparing plan?
This case is perfect. Let's run it through what you'd call the 60-second board script. That concise, defensible presentation you'd give in an exam.
I can do that. Let's imagine the clock is ticking. I'd adopt a very specific tone.
Go for it.
Adopts canned response tone. This is a 58-year-old never smoker with resected P, 16 positive left tonsillar squamous cell carcinoma after TORS, and ipsilateral neck dissection. He has 3 positive nodes and microextranodal extension of 0.8 millimeters with negative margins. Conventionally, extranodal extension is a high-risk feature that supports post-operative chemoradiation based on historic post-operative randomized data, and I would state that standard first on boards. However, in the post-TORS P16 positive population, the E18b trial risk-stratified patients and tested reduced-dose radiation alone for intermediate-risk disease. In that specific framework, extranodal extension at or below 1 millimeter and up to 4 positive nodes are classified as intermediate risk and treated with radiation alone, with excellent disease control. Given his extranodal extension of 0.8 millimeters at 3 nodes, I would discuss 2 defensible approaches with the patient. Conventional chemoradiation versus risk-adapted radiation alone per E18b. If pursuing the E18b approach, I would treat with radiation alone to 50 to 60 grays, depending on institutional practice and cumulative intermediate risk burden. For volume selection, this is a well-lateralized tonsil primary without posterior pharyngeal wall involvement and without contralateral nodes, so ipsilateral neck radiation is appropriate. My planning priority is swallowing preservation by minimizing dose to the pharyngeal constrictors and laryngeal structures whenever they are outside the target.
That is just a masterclass in how to present a complex case. It's got all the nuance, and it's a perfect jumping-off point to explore why this population is so unique to plan.
Well, that nuance is everything, isn't it? The surgery itself, the TORS, it completely changes how we have to think about our target volumes compared to the resections we used to see.
So let's unpack that. What's so unique about planning a post-TORS oropharynx case? You've pointed out three big differences before.
The first, and maybe the most dangerous, is the surgical bed itself.
Okay.
After TORS, resection is so clean, so minimally invasive, which is great for the patient, obviously. But for us, it means the surgical bed is often tiny. You might only see a subtle indentation on the planning CT.
And if that's all you contour?
You're in big trouble. It is so easy to miss the real target. If you just contour that little visible defect on the post-op scan, you are almost guaranteed to under-contour the true at-risk volume. You have to anchor it to the pre-op imaging in the op note.
So the risk of a geographic miss is actually higher because the surgery was so precise? That's counterintuitive.
It is, exactly. The second unique thing is the dose structure. It's truly risk-tiered.
What do you mean by that?
In most other post-op head and neck sites, you're pretty much defaulting to 60 or 66 gray, but here, E18b specifically tested a reduced dose of 50 gray for these intermediate risk patients.
Just 2 grays per fraction.
Right. It's formal, data-driven de-escalation. It was designed specifically to cut toxicity while keeping control high. It's a completely different philosophy.
And the third point, which really defines their life for the next 20, 30 years.
Swallowing. Swallowing preservation.
Yeah.
This is the functional outcome we can impact the most. These are long-term survivors. Their biggest long-term problem is going to be dysphagia, difficulty swallowing. If we're not using modern swallowing-sparing IMRT techniques to actively protect the pharyngeal constrictors, the larynx, we are failing them.
It's not just about covering the target. It's about engineering their quality of life for decades to come.
That's it, exactly.
Perfect. So let's get into the weeds of the E18b trial framework. Understanding these specific risk tiers is what drives the whole plan for our patient.
Right, so E18b took resected P, 16 positive oropharynx patients, all treated with TORS and a neck dissection, and it put them on a very clear 3-rung risk ladder based purely on their pathology.
Okay, let's start at the bottom of the ladder. The most favorable group, the patients who got to skip radiation entirely. That's Arm A, the low-risk observation group.
The criteria here were incredibly strict. You had to have a small primary, a T1 or T2. The margins had to be negative, and not just negative, but more than 3 millimeters.
So a nice wide margin.
A wide margin. Nodal status could be N0 up to N1, but, and this is the key, absolutely no extranodal extension, 0.
And if you met all of that,
treatment was observation. But the pearl here is that this is low enough risk to safely observe in a trial. It's not 0 risk. You still have to follow these patients very closely.
Right. Moving up the ladder, this is where our patient lives. The intermediate risk group. Too risky to watch, but maybe not sick enough for chemo. Arms B and C.
Yep. So intermediate risk is defined by having any one of 3 key features. First, closed margins, that's negative, but less than 3 millimeters.
Our patient had 4, so he just missed that one.
He did. The second is N1 to N2 disease with ENE at or below 1 millimeter.
Yeah.
And that is exactly where our patient falls with his 0.8 millimeter ENE.
And what's the third way to get into this group?
Just having up to 4 positive lymph nodes, even if there's no ENE at all. Our patient had 3 nodes, so he actually qualified on 2 counts.
So if you fall into any of those intermediate buckets, the E18b approach is post-op radiation alone, no chemo.
No chemo. This is the core of the de-escalation strategy for HPV-positive disease.
And the trial was clever here, right? They tested 2 different dose levels for this group.
They did, which gives us some flexibility. Arm B was the real de-escalation, 50 gray and 25 fractions. Arm C was a bit higher, 60 gray and 30 fractions.
And the big takeaway.
Both arms had excellent disease control. It really challenged the old idea that you always needed 60 or 66 gray. The 50 gray arm is the true functional de-escalation. It's designed to spare normal tissue.
Okay, top of the ladder, Arm D, the high-risk group. What pathology sends you straight back to chemoradiation?
This is for any of the major red flags. First, a positive surgical margin. Tumor at the ankle.
Can't get worse than that.
Nope. Second, extranodal extension that is greater than 1 millimeter. so 1.1 millimeters or more, and third, having 5 or more metastatic lymph nodes.
So if you hit any of those, you're back to the old standard.
You are. The treatment is full-on post-operative chemoradiation. 66 gray with weekly cisplatin, 40 milligrams per meter squared.
So the most critical number in this whole thing, the one you have to have memorized for boards, is that 1 millimeter ENE threshold.
It is the sharpest dividing line we have. It's the difference between radiation alone and adding systemic therapy.
Now, let's talk about the other things on our patient's path report. He had PNI and LVI, perineural and lymphovascular invasion. Where do those fit in? Historically, those are bad actors.
They are, and it's a critical point. In E18b, PNI and LVI were deliberately not used as stratification factors.
So even though they were present, they didn't automatically bump him up to a higher risk group?
Exactly. The trials showed that even if those features are present, as long as the main drivers, the margin status and the amount of ENE were favorable, radiation alone was still enough.
But this is where the choice between 50 and 60 gray comes into play, isn't it? Our patient with 0.8 ENE technically qualifies for 50 gray, but he also has PNI and LVI.
That is the perfect clinical scenario for a discussion.
Yeah.
For a more conservative approach, or when you have these multiple soft intermediate risk factors piling up, many of us would choose the 60 gray option.
So it's still within the radiation alone intermediate risk arm, but it gives you a little more dose to cover that cumulative risk.
It's a very reasonable clinical compromise. It acknowledges the extra risk without jumping all the way to chemotherapy.
Okay, what about this scenario? What if the pathologist just writes extranodal extension present and doesn't give you a number? What do you do?
You're in clinic, you're on boards, you have to state that your first step is to pick up the phone. You call the pathology department and you ask them to please quantify it. You need that number.
And if they can't, the specimen is gone, it's not possible.
If you truly cannot get a number, you have to default to the most conservative standard. You have to assume it could be large ENE and treat it as high risk.
So chemoradiation.
Chemoradiation. You can't risk under-treating it. The board-safe framing is always the same.
Let's hear it one more time.
Conventionally, ENE supports chemoradiation. However, in resected P, 16 positive post-TORS patients, E18b showed that micro-ENE at or below 1 millimeter can be managed with radiation alone. That's the script.
Perfect. That nails the risk stratification. So now let's apply that in our next big decision for this patient, the volume. We know he's intermediate risk, so radiation alone, but should we treat just the left side of his neck, or do we need to go bilateral?
For these very specific, well-lateralized tonsil primaries, the data is very strong in supporting ipsilateral or one-sided neck radiation.
And why is that?
Because when you look at the data, the rate of the cancer coming back on the other, untreated side of the neck is incredibly low, often less than 3%.
And going from bilateral to unilateral treatment is a huge win for quality of life.
Massive. Mostly by sparing the contralateral parotid gland and other swallowing structures. It's a big deal.
But you can't just do it for everyone. What are the absolute non-negotiable criteria you have to meet to justify treating only one side of the neck?
You have to meet all of these. There's no picking and choosing. First, the primary has to be confined to the tonsil or lateral pharyngeal wall. Clearly lateralized, no crossing the midline. Second, no base of tongue extension at all. Third, absolutely no posterior pharyngeal wall involvement. That's a huge red flag for midline drainage.
Got it.
Fourth, no contralateral lymph nodes on exam or any of the imaging, especially that pretreatment PET-CT. And finally, no significant soft palate extension that's creeping towards the midline.
And if any of those are violated, you have to lean towards a bilateral treatment.
The caution flag goes up immediately. You at least have to have a serious discussion about it.
What are some of those other caution flags? What else might push you to treat bilaterally even if the primary looks pretty lateralized?
If you have really bulky nodal disease on the one side, say massive nodes in levels 2, 3, and 4, that sheer volume of disease just statistically increases the risk of microscopic spread to the other side.
Makes sense.
Another one is extensive level 2 disease that's right up against the midline soft tissues. Just the physical proximity is a risk. And of course, if there's any ambiguity at all in the surgeon's note or on the imaging.
And what's the one hard and fast rule? The absolute contraindication for unilateral treatment?
Base of tongue primaries. The lymphatic drainage of the base of the tongue is just so rich and it crosses the midline so freely, you almost always have to treat both sides of the neck, regardless of how it looks.
So for our case, patient left tonsil only, no funny business. We are safe and totally justified in treating the ipsilateral neck only.
Yes. The board-safe summary for this would be, Given the tumor is a well-lateralized tonsil primary without base of tongue or posterior wall involvement and no contralateral nodes, I would treat the ipsilateral neck only, covering levels 2, 3, and 4.
Great. We have the risk, the dose, and the volume. Now for the really technical part, the planning workshop. How do we draw these lines on the screen?
It starts with a step that is, I think, the source of the most common errors: reconstructing that primary surgical bed.
Okay.
I like to use an analogy here. I call it forensic architecture. You're trying to rebuild a structure that's been altered, and you need 3 key documents, 3 anchors, to do it right.
I like that. What's anchor number 1?
Anchor 1 is your preoperative imaging, the MRI or the PET-CT that shows the tumor before it was touched. You have to fuse that scan perfectly to your planning CT. It shows you where the tumor lived.
Okay, anchor 2.
The operative note. This is the surgeon's map. It tells you the boundaries of the resection, what they took, where they put the clips.
And the clips aren't the whole target.
No, they're just markers. Anchor 3 is the pathology report. It confirms the margins, tells you where any P&I was, and gives you that all-important E&E measurement.
And without all 3 of those anchors,
your contour is an educated guess, at best. You're running a huge risk of a geographic miss in a patient you are expected to cure.
Okay, so step 2. We've got our anchors. How do we define the actual primary surgical bed CTV?
The CTV has to be the union of all those things: the pre-op tumor footprint, the resection boundaries from the op node, and the whole anatomic corridor that's at risk.
So for a tonsil primary, what's on that anatomic checklist?
You need to cover the entire tonsillar fossa, the lateral pharyngeal wall right next to it, the glossotonsillar sulcus, which is that little groove where the tonsil meets the tongue.
Right.
The deep margin is defined by the original tumor depth plus a bit of a margin, maybe 5 to 10 millimeters, into the soft tissue. You're covering the superior constrictor muscle and pushing into the parapharyngeal space to cover that deep surgical plane.
And where do you stop? What are the hard anatomical barriers where you can safely edit your contour?
You respect dense bone, like the mandible or the pterygoid plates, unless pathology says it was involved. You respect the prevertebral fascia in the back. That's a very strong barrier. And of course, you respect air. You don't contour into the throat unless the tumor was growing there.
So the philosophy is fuse the pre-op scan, add a small smart expansion based on anatomy, and then edit back to those hard barriers.
Exactly. The goal is to avoid that geographic miss.
Okay, primary bed is secure. Now for the neck CTV. The rule for a dissected neck is fundamental, right?
You treat the entire nodal level as a compartment. You do not fall into the trap of just drawing a little circle around the surgical clips. That is a classic junior resident mistake.
The clips just show where the bulky disease was, not where the microscopic disease might still be.
Precisely.
So for our patient's ipsilateral plan, what levels are we talking about?
You have to cover level 2A and 2B and all of level 3. Now, since our patient had positive nodes, we have to think about level 4.
And you'd include it?
For him, yes. With 3 positive nodes, including level 4, is the standard conservative choice. It's the next station down the lymphatic highway. You want to cover it.
Let's talk about the retropharyngeal nodes. They can be tricky to treat without giving a lot of dose to the swallowing muscles. When can we safely leave them out?
The decision rule for retropharyngeal nodes is all about the primary tumor's location. You can reasonably omit them if the primary is perfectly lateralized like our patients. No posterior pharyngeal wall involvement, no base of tongue, and no suspicious nodes there on the pre-op scans.
And when you have to include them?
You must include them if there's any posterior pharyngeal wall involvement, any base of tongue extension, or really bulky level 2 disease that's pushing back towards them. But for our patient, omitting them is a reasonable choice, and it's a key step in minimizing goes to the constrictors.
That level of detail is exactly why we're doing this. So step 4, dose tiering. Let's just formalize the prescription. What are the 2 radiation-alone options again?
Option 1 is 50 gray in 25 fractions. That's the true de-escalation arm from the trial. Option 2 is 60 gray in 30 fractions, the more standard post-op dose, but still without chemo.
And how do you choose between them in practice?
I think you should frame it this way. 50 gray is the best choice for a patient who barely qualified for intermediate risk. Say their only risk factor was a 2 millimeter margin. That's the purest function-sparing approach.
But for our patient?
For our patient, who has cumulative risk factors, 3 nodes, plus micro-E&E, plus P&I and LVI leaning towards 60 gray, is very common and very defensible. It's a conservative buffer that acknowledges that higher risk burden, all while staying in the chemo-sparing arm.
And just to close the loop, if his E&E had been 1.4 millimeters.
Then it's 66 gray with weekly cisplatin. No debate. The high-risk features demand the higher dose and the systemic therapy.
And finally, step 5 is the PTV expansion.
Yep, that's your standard 3 to 5 millimeter isotropic margin around the CTV to account for daily setup variations.
Okay. We need to really spend some time on the swallowing-sparing OARs, the organs at risk, because you said it earlier, this is what defines their life.
It really is. For these patients, survival is expected to be excellent, 80–90%. We're giving them decades back. The number one threat to their quality of life over those decades is swallowing problems. The dose we deliver to their swallowing anatomy is something we can directly control.
So what are the priority targets for sparing, assuming they're outside of our main CTV?
We focus on the DARs, the dysphagy aspiration-related structures. That starts with the pharyngeal constrictors, the muscles that push food down, then the larynx and the supraglottic structures which protect the airway.
Right.
And in a case like this, where we're only treating one side, we have this golden opportunity to spare the contralateral parotid and submandibular gland to keep their saliva production up.
And what's the board-safe evidence statement you need to make about this?
You need to say something like, dose to dysphagy aspiration-related structures is modifiable, and dysphagia-optimized IMRT is proven to improve patient-reported swallowing outcomes. It shows you're thinking strategically.
Let's get practical. What are the dose constraints for the constrictors?
If the constrictors are outside your main target, your goal is a mean dose of less than 50 grays. The data is pretty strong that keeping the mean dose below that level leads to much better long-term swallowing.
And the larynx?
If the larynx isn't in the target, we aim for a mean dose under 35 to 40 grays. It really helps with voice quality and aspiration risk.
And finally, the glands. With an ipsilateral plan, what's the goal for that contralateral parotid?
That gland is the saliva workhorse. You want the mean dose to be less than 10 gray and ideally less than 7. It's very achievable with modern planning, and it makes a world of difference in preventing that life-altering chronic dry mouth.
This is great. We've covered the risk, the volume, the dose, the OARs. Let's talk about how you actually explain all of this to the patient.
This requires a lot of transparency, especially in this intermediate risk zone where there are two defensible options.
So what's the language you use?
I would say something like this. Your pathology report has a lot of good news. It's HPV positive, and the surgeon got it all out with clear margins. However, there were 3 affected lymph nodes, and we saw a tiny, microscopic amount of spread less than a millimeter just outside one of them. Because of that finding, we need to do some cleanup treatment. Now, we have 2 excellent options, and both give you a fantastic chance of cure. The traditional path would be radiation with chemotherapy. A more modern risk-adapted path, based on a huge clinical trial, shows that because that microscopic spread is so small, we can get the same excellent cancer control with radiation alone and avoid all the side effects of chemo. Our plan is to prioritize avoiding chemo, treating early the left side of your neck to protect your saliva, and using special techniques to spare your swallowing muscles.
That's perfect. It's reassuring, but it's honest. And it frames the choice as an optimization for their quality of life, not as cutting corners on their cancer treatment.
Exactly.
All right, let's pivot to our oral board traps segment. We've identified 3 huge pitfalls that people fall into with this exact scenario.
Trap number 1, I call the reflexive chemoradiation trap.
Okay.
This is just seeing E&E on a report and reflexively saying chemotherapy. It's a failure to apply the modern nuance. You have to remember the 1 millimeter exception from E18b for this specific group. If you miss that, you've missed the current standard of care.
And the safe answer is that 2-step approach. State the old standard, then introduce the new data.
Always.
Yeah.
Trap number 2 is the volume overkill trap.
Treating both sides of the neck when you don't have to.
Yes. If the patient meets all those strict criteria for ipsilateral-only treatment, treating the other side of the neck is just guaranteeing worse side effects, more dry mouth, more swallowing trouble for no proven benefit.
Don't be too conservative if the anatomy doesn't require it. And trap 3.
The planning trap. Contouring only the visible post-op defect.
This is a planning disaster.
It is. Your CPV will be too small. The tissue shrinks and heals. If you only contour what you can see on that post-op scan, you will miss the true footprint of the original tumor. You must use the 3 anchors we talked about.
Pre-op imaging, op note, path report. Got it. So let's crystallize this with our 6 high-yield clinical pearls, the absolute takeaways.
Pearl 1, E18b. Intermediate risk is defined by close margins. E&E at or below 1 millimeter, or up to 4 nodes. For these patients, radiation alone to 50 or 60 Gray is defensible.
Pearl 2. High risk is positive margins, ENE greater than 1 millimeter or 5 or more nodes. That mandates chemoradiation to 66 Gray.
Pearl 3. Ipsilateral neck radiation is a huge quality of life win, and it's supported by data for well-selected lateralized tonsil primaries.
Pearl 4. Swallowing sparing is a top planning priority. You have to actively minimize constrictor and laryngeal dose whenever it's safe to do so.
Pearl 5. Reconstruct the post-TORS bed from the 3 anchors pre-op imaging op-no pathology. Don't trust the post-op defect alone.
And Pearl 6, the practical one.
Always, always ask pathology to quantify the E&E measurement. Present is not good enough. It creates uncertainty and might force you down a more toxic treatment path unnecessarily.
Fantastic. Let's wrap this up with our board review blitz rapid-fire questions.
Let's do it.
Question 1 on high risk. A patient has post-TORS P16 positive tonsil cancer with ENE measuring 1.4 millimeters. Margins are negative. What is the most appropriate adjuvant therapy? A. Observation. B. Radiation alone, 50 Gray. C. Radiation alone, 60 Gray. Or D. Chemoradiation, 66 Gray with weekly cisplatin.
The answer is D. Chemoradiation 66 Gray with cisplatin. The rationale is simple. ENE greater than 1 millimeter is the high-risk trigger in E18b. That mandates chemo.
Perfect. Question 2 on volume and intermediate risk. A 55-year-old with a P16 positive left tonsil cancer confined to the fossa. Pathology. 3 positive nodes, no ENE, but a close margin of 2 millimeters. No posterior pharyngeal wall involvement, no contralateral nodes. What's the treatment and volume? A. Observation. B. Bilateral neck radiation. C. Ipsilateral neck radiation. Or D. Bilateral neck chemoradiation.
The answer is C. Ipsilateral neck radiation 50 to 60 Gray.
Right.
This patient is intermediate risk because of that close margin 2 millimeters is less than 3 and the multiple positive nodes. And critically, the disease is perfectly lateralized, so she is a great candidate for the function-sparing ipsilateral neck approach.
Final question on OAR priority. When planning post-TORS radiation for these patients, what's the most important functional consideration for optimizing long-term outcomes? A. Minimizing spinal cord dose. B. Minimizing dose to dysphagia aspiration-related structures. C. Avoiding mandible hotspots. Or D. Sparing the brachial plexus.
The answer is B. Minimizing dose to the dysphagia aspiration-related structures. All the others are important, but for these long-term survivors, swallowing dysfunction is the dominant, modifiable morbidity. Scaring the constrictors and larynx is the top priority for their quality of life.
So today, we really did a comprehensive workshop on the technical execution of post-TORS radiation. We walked through that critical E18b risk algorithm, sorting patients into observation, radiation alone, or chemoradiation.
And we detailed why you absolutely have to reconstruct that subtle surgical bed using the 3 anchors pre-op imaging, the op note, the pathology. The visible defect is just not enough.
We laid out the strict criteria for when you can safely treat one side of the neck versus both, and why that matters so much for long-term function.
And finally, we just kept hammering the point that swallowing sparing isn't a bonus, it's a primary goal. You have to actively plan to protect the constrictors and the larynx to specific dose constraints.
In our next session, we're going to tackle some of the tougher scenarios that really contrast with this favorable population. We'll get into the aggressive HPV-negative head and neck cancers, the whole workup for an unknown primary, and the really challenging world of salvage treatment, including reirradiation.
Complete practice oral boards at radoncsmartlearn.com and subscribe to Rad Onc Smart Review for our next session. Thank you for tuning in.